another corneal surgeon with us, Dr. Sujatha ma'am, and she is the Associate Medical Director at Rajan Eye Care in Chennai, and she is also the head of the Rotary Rajan Eye Bank over there. And I must mention that she is a recipient of a very coveted Nari Shakti Puraskar recently for her philanthropic work for eliminating the corneal blindness. We look forward to hear from you, ma'am.
Thank you, everybody. At the outset, I'd like to thank WAS, Mohita Sharma, and the scientific committee for giving me this opportunity. I'm just going to show you 3 videos because I've been given only 6 minutes of DALC and challenging situations. These situations are achieving the big bubble, how to do a manual dissection, and managing a perforation to convert or to proceed. So my go-to in getting a big bubble is using a 30 gauge needle and injecting it deep into the stroma and forming a big bubble. Once you get a big bubble, then it becomes very easy. The whole procedure becomes very easy. Then you just need to do a dissection of the stroma above the decimates, very carefully at all times, making sure that the eye is soft by decompressing the anterior chamber. And these bubbles usually form, you get very nice bubbles with keratoconus patients, anterior dystrophy patients, but some macular dystrophy, it's very difficult to get. So you can see that once you've got the decimates exposed, then you can go ahead with removing the endothelium from the donor graft. And normally I prefer to use the same size donor and complete the surgery, particularly in DALC. This is again a patient with keratoconus with an excellent big bubble. This is actually my first case done in 2004. So this is how the whole thing goes, and the graft is sutured with interrupted sutures, and the procedure is complete. So coming to the next case where I had a problem. Let's see, I got a very nice bubble first. You see, this is a patient with macular dystrophy, and I really had a doubt whether I'll be able to get a bubble. I did a superficial keratectomy. So I injected air, but it went into the anterior chamber, it decompressed, and again gave an injection, got a type 2 bubble, which is smaller, and I re-roofed the bubble. But unfortunately, in my enthusiasm, I did it again. That is a big mistake. And I touched the DM, and you can see some aqueous coming out. So actually, I had punctured the bubble. And now my problem was that all the air is lost. I was not able to find the plane. And so the question is, so I decided to go ahead with the manual dissection. And you can see as I'm doing the manual dissection, the air from the anterior chamber keeps escaping. So the best thing would be to do a suturing. Just suture the air, suture the area of the defect, and continue with the dissection. Now I identify the bubble of the original bubble. So again, I de-roof the bubble. And once I got into that plane, then everything becomes easy. Now, when I injected viscoelastic, we can see that it is separating the Descemet's membrane from the superficial stroma. Then you can go and give multiple cuts using a blunt tip varnish and then expose the endothelium. So in this case, because the bubble was not complete, the periphery needed a little bit more dissection. So to make sure that completely the graft will be sitting properly. And the last thing to do is to remove the suture. And then you can go ahead with removing the endothelium from the donor and using a same size graft. Using a same size graft, particularly in perforation, helps because the chance of double AC is less. This is a pre and the post-operative picture. And you can see the area of perforation as well. A little bit of graft edema persisted for some time, and then by the end of 1 month, he was perfectly all right. So coming to the next case, this again a patient with a stromal dystrophy. And normally I prefer to put a Fleringer ring on all my cases because in case I need to convert, because most of these patients are young patients, and I always put them under GA. And just to make it quick, you can see that I was not able to achieve the bubble. So I started doing a manual dissection, and there was quite a lot of scarring in this in the dystrophy. So it was quite difficult to do the manual dissection. But nevertheless, I thought it's better to have a DALC, even if it's a partial near total DALC, than to go in for a full thickness. See, you can see again one more perforation. So I injected air. The perforation was quite large, and I was not able to continue with the procedure. So I sutured it. So So, in suturing, once you suture, then the air stays behind and then you are able to remove the rest of the stroma. That's a great advantage. And then once you remove the stroma as much as possible, you can go ahead and suture the graft which has been prepared already. So this is the post-op. You can see the suture in the interface and the graft is quite clear for the first post-op day. So this is again a patient who had a graft perforation. You can see the post-op, you can see the area of perforation, but these grafts really clear up. And I do an inferior PI in these patients so that I can have a complete airfill. So that prevents an anterior chamber collapsing. This is the last case which I'm going to show you. It's an unresolved hydrops. Patient was having hydrops for more than 15 days. So I gave an air injection, which didn't suffice. So took her up for a venting incisions, followed by an injection of non-expansile C3F8. And because the C3F8 remains in the anterior chamber for a longer time, usually this works very well. In most of my patients, they have really responded well to this. But in the first day post-op, there was some clarity, but you can see that now the whole thing has opened up and it was like an impending perforation. And the graft edema actually had increased much more, as you see in the ASOCT. So I gave air injection just to facilitate my dissection, manual dissection. So, I mean, it's not a conventional method to do during an active eye drops to do a DALC. But in this case, the patient was already 1 month into this eye drops, not responding because of the size of the eye drops. And there was a potential for impending perforation. So with a combination of 15 number blade and a crescent knife, I did the maximum dissection as possible and sutured the graft. So this patient actually did pretty well, and post-operatively, she had actually a high myopia as well. So in addition to her myopia, so you can see the area of perforation. This central area was perforated, and you can see the irregular thickness of the stroma in the first week, but over a period of time, it became extremely thin once endothelium started working, and she did very well. So some of the post-operative complications are AAC, Descemet's membrane folds, particularly in keratoconus, delayed epithelialization, stromal melt, infections, interface haze, high astigmatism. So this is a patient with an AAC. AAC, the best thing would be to give an air injection and push in the patient. Otherwise, if it's a recurrent, then you go for a C3F8 or SF6 gas. Or in a persistent AAC, I've even changed a graft to a smaller size graft. So again, another problem with DALC is delayed epithelial healing, as you can see, because of graft host disparity. Thinner corneas, when they keep a thick donor.
Sorry, doctor, to interrupt in between, but the time is now over, and I request you to please wrap up in the next 30 seconds.
So this is persistent epithelial defect. So DM folds, high astigmatism, or some of the complications associated with DALC. So it has a long learning curve, and it's important that you practice on eyes and go to wet labs to get the best results. Thank you once again.